Well, what do we know about management of perioperative anaphylaxis up until NAP6? Well, all the studies have demonstrated, all the guidelines have stated that adrenaline is the mainstay of treatment. We know from some case reports that glucagon is more effective than adrenaline in refractory hypotension in patients taking beta blockers. And we know from other published work that other vasoactive drugs are commonly used in addition to adrenaline, sometimes instead of, and they may be effective. We don't know how effective. We know from previous studies that large volumes of intravenous fluids should be administered. It goes without saying that in cardiac arrest, ALS protocols should be followed. And although there are no RCTs in perioperative anaphylaxis, it's generally accepted that steroids are beneficial. Antihistamines we'll come to in a minute. There is good evidence that antihistamines improve urticaria and swelling in allergic reactions. Less good evidence in anaphylaxis related to outcomes. What do we know about adrenaline? Well, yes, adrenaline should be given, but we need to accept that most hypotension observed during anaesthesia is not related to anaphylaxis, and that it's unlikely that adrenaline is going to be the first drug. In fact, we'd hope that it isn't in the usual form of hypotension we see. As we discussed before, adrenaline is very useful because it has beta agonist properties, whereas, as you know, metronidazole doesn't. And beta agonist properties are needed for normalizing the ATP-AMP ratio within mast cells, reducing mast cell granulation, or the propensity to degranulate mast cells. How much adrenaline? The AGBI guidelines 2009 recommend 50 micrograms repeated as necessary, 50 mics being the smallest dose, 0.5 ml, that you can give of the pre-filled syringe of 1 in 10,000 adrenaline. More recently, in fact, quite recently, the Australia and New Zealand anaesthetic allergy group guidelines recommended larger doses, more aggressive adrenaline management, 100 mics as an initial bolus, followed by between 100 and 200 micrograms every 2 minutes, followed by an infusion after the third bolus, straight onto an infusion, which is quite interesting. And we know from a Danish study that there is reluctance, or there appears to be reluctance, for anaesthetists to actually give adrenaline, and that is not really surprising. And we've discussed the possible reasons for that in the report. So what did we find? You've seen the graph on the left previously. It shows the elapsed time between the administration of the suspected trigger agent and recognition of the critical incident, and number 1 and number 2 suspecting anaphylaxis. And the critical incident was recognized within 5 minutes in 60% of patients, and anaphylaxis was suspected within 5 minutes in 50% of patients. That's the left-hand column. We reviewed the promptness, the panel reviewed as a consensus the promptness of management, and we judged that recognition of the critical incident and suspecting anaphylaxis was prompt in 97% of cases. Now, that might seem overly lenient when you look at the numbers to the right of the first columns there, but bear in mind that the clock started in relation to that chart at the time of administration of the trigger agent. So the first few minutes may well have been taken up with the evolution of anaphylaxis, which is not instant. So I think the two figures are not at odds, actually. I think they're compatible. On the right-hand side there is the speed of starting anaphylaxis-specific treatment after the first clinical feature had appeared, whatever that was, in minutes. And in 2/3 of cases, first column there, you can see that anaphylaxis-specific treatment was started within 5 minutes of the first clinical feature. It would have been quite nice to be able to say, was it 1, 2, 3, or 4 minutes? But actually, as we know, anaesthetic charts, rarely, unless they're automated, would rarely enable local coordinators to provide those data. So we were looking at 5-minute intervals. And the review panel judged that the response in terms of starting anaphylaxis-specific treatment was prompt in 83% of cases, so slightly less good performance. What about administration of adrenaline? One might expect that adrenaline would be administered to all cases. These are all grade 3 and upwards. They're all life-threatening. They're all very severe cases. Adrenaline was not administered at all in, as you can see, almost 18% of cases. And there are an additional small proportion where adrenaline was given, we judged, rather late in the proceedings and should really have been given earlier. So that was a somewhat surprising and interesting outcome and also a pointer to possible improvements in the future. It was interesting that almost 1/3 of patients went on to receive an intravenous infusion of adrenaline. One of our recommendations that we made is that as soon as you've given the first dose of adrenaline, it's a good idea to be thinking about getting somebody to help you to prepare an infusion, because you're quite likely to need an infusion, so that there are not undue delays. The IM route was used in 14%, which I found a little surprising. I was surprised it was as high as that. And both routes, obviously the IM route didn't do the trick in a small proportion of cases. What about the dose of adrenaline? Broad brush, those are medians. Grade 3 patients received 200 mics total, grade 4, 500, and of course the grade 5 were the unfortunate fatalities. And they'd been, most of them, through several cycles of the cardiac arrest algorithm. And the median dose was 4 milligrams. So why was it that adrenaline wasn't administered in some cases? Well, we can get some feeling about that from some of the narrative, the verbatim narrative provided by local coordinators on the right there. Some of them you might think justify not giving adrenaline, perhaps. I'm not sure I do. The second narrative there, metaraminol was given as there was a history of coronary artery disease, does betray a lack of confidence in giving adrenaline in patients with coronary artery disease that isn't borne out by published work, which demonstrates that isn't a particular risk factor in relation to giving adrenaline. Give adrenaline, even if there is coronary artery disease, is our recommendation. And the last comment there is rather sad, that there was a delay in adrenaline being brought. I had naively assumed that adrenaline was available wherever anaesthetics are given, immediately available. Clearly not, and that is also, you'll find, one of our recommendations, that it should be. Metaraminol was given first in almost 70% of cases. That's the arrow. You probably won't be able to read the x-axis there. Adrenaline is the first column, and then the signposted column there is metaraminol. It's not too surprising, but it doesn't have any beta agonist effect. The second bullet point, I think, was very interesting, and that is that noradrenaline infusion was administered in almost 1 in 5 patients. So this is an indication that this is an ongoing process, perioperative anaphylaxis. This is not something that happens instantly, we know that, and it's not something that is abolished instantly by giving adrenaline. This is an ongoing process. Many of these patients needed vasoactive infusions going right through into critical care and for some hours in critical care. So that's quite an interesting outcome. Phenylephrine, as we would expect, was administered mainly in obstetric cases where it's the vasopressor of choice, if you like, rather than metaraminol. I can't read too much into that. Only 2 patients received vasopressin for refractory hypotension. One might have hoped perhaps a few more. The last bullet point there I think is important. 18% of patients were taking a beta blocker, but only 1 received glucagon. And we were able to identify an association between beta blockade and poor outcome. So one of our recommendations very strongly is that glucagon should be available. It's available for use in diabetes, in pre-filled syringes. It should be available not in every anaesthetic room, but it should be available within a short period of time to every patient who is under the care of an anaesthetist receiving drugs. So a plea for glucagon, I think, comes out of our NAP6 data. Steroids and then antihistamines. We touched on steroids earlier. The activity survey demonstrated that Dex is given as an antiemetic in 60% of all general anaesthetics. So fewer are in the total cases, but in about 60% of all the general anaesthetics as an antiemetic. And although we usually give 6.6 milligrams, the data are that 7.5 milligrams is equivalent to hydrocortisone 200 milligrams. So with dexamethasone, we're giving a significant hydrocortisone equivalent. And as we discussed earlier, dexamethasone certainly doesn't prevent anaphylaxis. We were unable to say whether pre-administered dexamethasone influenced the process of anaphylaxis. That would be impossible from the data. Chlorphenamine is the UK anaesthetists' favourite IV antihistamine. In Australasia, they tend not to use chlorphenamine. It was administered in about 3/4 of cases. 5% received ranitidine as well, which is interesting. Now, we were particularly interested to know whether chlorphenamine was of benefit, because really there are very few data relating to antihistamines in anaphylaxis as opposed to mild allergic responses with cutaneous features. Unfortunately, I have to tell you that we can't tell you. So the first thing, and thanks to Mark Bellamy for doing the statistics on this, the first thing was we did demonstrate an increased probability of no harm with an odds ratio of 2.2 and a decreased probability of moderate to severe harm using univariate logistic regression using patient factors and resuscitation drugs as variables. The OR for probability of moderate severe harm was 0.41. But I think we did the right thing, and thank you, Mark, for going further to say, well, actually, was that because the administration of chlorphenamine was just part and parcel of good treatment? In other words, plenty of intravenous fluids, getting onto it quickly, giving adrenaline as opposed to not, all those other sorts of things, some of which are quantifiable, some of which are not. And using a Fisher exact test, chlorphenamine administration was strongly associated with good as opposed to good and poor or poor clinical management. So we weren't able to extricate chlorphenamine, the efficacy of chlorphenamine per se in terms of outcome, which was a disappointment. Bronchospasm was present in almost half the cases. A specific bronchodilator, somewhat surprisingly, was only used in a quarter. And I think the inference is that adrenaline is a jolly good bronchodilator. The right-hand graph there shows which bronchodilators were used and the percentage of cases they were used in, and you can see that inhaled salbutamol there was the largest column, but even then only between 10 and 12% of patients received it. A small number of patients on the right there received ketamine and a small number on the left aminophylline. I think it's quite interesting that 7.4% of patients received magnesium sulfate for bronchospasm, which is a very good drug for bronchospasm. But we came to the conclusion that it may not be a very good drug for bronchospasm in the presence of severe hypotension, because given in the doses that were recorded, magnesium sulfate, even in patients with a normal cardiovascular system, can be associated with hypotension. So the big question is, does magnesium sulfate given for bronchospasm in perioperative anaphylaxis exacerbate hypotension? We can't answer that specifically, but we could probably say that caution should be applied when giving magnesium sulfate under those circumstances. And of course, under other circumstances, it's an excellent drug. Now, another big question we couldn't answer is this one. I think simply because it was only given to a small number of cases. So, Sugammadex, as you know, there have been some case reports suggesting efficacy in rocuronium anaphylaxis, and it was administered during the first 6 hours after the event in 19 cases, and those are the doses and the range. Now, in 9 of those 19 cases, rocuronium was suspected to be the trigger agent, and in 7 it was the actual trigger agent. So in 12 of the patients who received Sugammadex, it wasn't the trigger agent. Did it work? Well, no more specific anaphylaxis treatment was needed in 57%, just over half, trial like Brexit. But further vasopressors, bronchodilators were needed in 43%. A similar proportion was seen, though, in the patients who had non-rocuronium-induced anaphylaxis and received Sugammadex. So I don't think we can say, the consensus was that we can't say that Sugammadex was effective. And last bullet point there, our results there are compatible with a case series reported by Platt 2015, who demonstrated that Sugammadex seemed to be equally effective or ineffective, regardless of whether rocuronium was a cause or antibiotics. And we don't know why. Okay, I need to stop there. Thank you very much indeed. There we go.
I think what the audience can't see is there's a very large red screen here that says to Nigel, "Time's up."
With a picture of a gun. No, it doesn't.
So I was wondering whether I was actually allowed to pull Nigel off the stage, and Liam said, of course, go and have a go at it. Anyway, next we have Dr. Thomas Garces, who is a clinical immunologist from Manchester, and Thomas is going to tell us about the NAP6 tools. Thank you.